So trying to make a contribution in the landscape that we're in is probably something that everybody in this call has wanted to do, and it has been the most extraordinarily challenging thing to do. And when things are really difficult, what you want to be doing is collaborating and spending a lot of time. As to how Bernstein says, collaboration is a contact sport. But what we've been faced with is the most difficult challenge that most of us will ever have in a landscape where you have to spend, 12, 16 hours a day on your own, sitting in front of your computer screen, trying to get some stuff done. And what has been really hard, I think, is working out how you land digital responses in a way which is coherent. And I went through a presentation very early on in this crisis, which was given, organised by McKinsey, and had some people who'd been involved in managing crises in different worlds, particularly an army fella. And he described the various phases of a crisis. You have initiation of a crisis, when everybody is kind of working out, oh, crikey, this is different now, there's something we need to do. And actually, everybody is trying to deal with the crisis, but there's no kind of maturity to that response. Everybody involutes a little bit at that particular stage because they're trying to work within the kind of command and control structures which they're confident and familiar with. And that's a very difficult time. And you obviously need to do things, and you need to do things fast. And I think from a Health Innovation Manchester perspective, we found that difficult. You then get into a sort of a crisis business as usual, if that doesn't sound ridiculous, a phase where those kind of governance structures become a little bit more mature, and you can work out and get that connectivity to work out actually what's going on, what are some of the problems you want to solve, and how can you solve those problems. And that's kind of probably the phase that we're in now. And then what you then get into is the phase of the crisis that actually will come next, which is moving towards a new normal, whatever that might mean, which it feels like we're starting to get to at the moment. So I think I just start off with those kind of that thought. I think the other thing that I'd like to just bring out here is this idea of these kind of 4 waves of this particular crisis, and this is kind of a slightly different lens on the same kind of question. And that's around the first wave being this wave of the epidemic, the first wave, and it feels like we I don't like to say that we're past the peak, but I would like to say we're kind of into the plateau now. It does seem like the numbers aren't escalating, but the numbers aren't, and the numbers are coming down, but they're not coming down, no rapidly. So that's the kind of the first phase. I think the second phase is people are thinking about is what happens in a second wave when you start to release lockdown measures and you get a second wave, and how can we minimise that in terms of the damage that causes. I think the third wave that people are talking about is this wave of unsurfaced and untreated disease, which has been a response to the COVID-19 direct care response. So the numbers of people accessing healthcare services for heart attacks, for stroke, or new cancers and stuff has gone right down because access has been hard and people have been scared. So I think everybody's anticipating a wave of that kind of coming through over coming kind of weeks and months. And recognizing that those things will need to be treated in a different way to minimise the infective nature of cross infection and nosocomial infection, etc. off the back of that. And then the fourth wave is the wave which is directly related to the responses to COVID-19. So the lockdown, the economic consequences, the social isolation, and what does that do in terms of people's mental health? What other kind of illness is going to be a consequence of the direct response? So I think there's something about understanding that there are these different waves, and I think that feels like quite a useful model. And actually what we've been doing in terms of our digital response is trying to play into those things. You hear me, by the way, Neil? So am I speaking to, yeah?
Loud and clear, yes.
Yeah, okay, great. So the first thing that we did as this stuff kicked in is to say, this is a once in 100-year crisis. We need to be focusing all our efforts in trying to deal with that crisis, recognizing that this thing was going to have a different way. So we went through everything that we were doing ruthlessly to say, yep, we're going to do this because this is important and we're going to accelerate it. Secondly, these things which we're not going to be doing. So we're absolutely going to stop those, and we'll probably never pick them up again. And then some things that we wanted to put on the back burner, particularly some of those things related to what I've just described as kind of phase 3 and phase 4 of the crisis. But actually, interestingly, nothing that we're really focusing on is stuff that we weren't focusing on before. We've just increased our focus on that. We're doing that in a slightly different way with an accelerated timescale. And I suspect all of you on the call will have been through a similar kind of process to this as we've been through. So what has come through from this is a slide that I've used for quite a few years since I left the technology business. But the history of this, and I'll just animate the slide through, is that historically, IT has kind of taken orders from the business and then moved to providing services to the business, to then aligning with the business to actually being the business. And as I've showed this slide over the last couple of years, I've questioned healthcare organizations to say, where are you at in this particular kind of hierarchy? And I think the vast majority of people would say they were either on the left or second to the left. Some would say they were, second from the right, but nobody would say they were absolutely on the right. But actually what's come through in terms of the things that we've done in terms of our response to the crisis is it's all been absolutely on the right. So all of the things that we've decided that we need to accelerate have been related to digital solutions to clearly defined business problems which are there in response to the COVID-19 thing. So this has accelerated our activities much more towards where we were going, because we've been quite loud and proud about saying Health Innovation Manchester is a digital organisation, digital is a business, the business is digital, and so that's one of the things that's come through clearly from this particular last couple of months' work. So I showed before the governance arrangements that we had were putting in place with a digital transformation board, a digital delivery executive. We hadn't got that over the line, but we did have a digital transformation board. But we recognised that having a big board was not the way of doing business in a crisis. So we formed a digital coordination group to help prioritise, steer, and get business done in this particular landscape. And as we did that, we were understanding what was going on in terms of the civic region command and control structures. And I don't know whether people know this, but it's quite important. So as part and parcel of the NHS response, all localities are required to have a kind of a governance structure. And for Greater Manchester, that's about having a hospital cell, which decides the COVID-19 direct response. And it's, one of those things has been set up the Nightingale service, but it's also been working, how do they work as providers in terms of providing the direct response to COVID-19 admissions and care, and an outer hospital cell. So those are the two goal command structures which exist. And of course, a lot of the work that we've been doing digitally actually cuts right across those two things. What's happened in Greater Manchester, because we have devolution, is a group that sits above that, which is a sort of strategic coordination group, which sits above the hospital cell and our hospital cell, and plays in the hospital to the wider public service response, which is so important in this extreme landscape that we're in. So we got agreement that we would set up this digital coordination group to work across those cells, which actually had the authority of those various different groups, which enables us to do business with that right connectivity, so that the priorities that we decided to pursue were agreed by those groups and subservient to their business objectives. But actually getting that governance sorted out was a really important thing that we evolved through the initiation of the crisis as we moved into crisis business as usual. So in terms of the priority programs that we set up, we started by having four. Fourth was resolving IG for accelerated data sharing. Second was about rapidly enhancing the care record. The third was around digital primary care, and the fourth was around digital long-term condition management. So resolving IG for direct care and secondary uses is something that we've been trying to crack for a long time. And what happened in response to COVID-19 is something came out which was called the COPI notice, which is a confidential patient information notice, which came out centrally, which required organizations to share data for the purposes of the COVID-19 response. And the purposes of the response were pretty wide and included direct care planning, evaluation of responses and research. So we have worked across the system to get agreement about how we have IG which everybody's comfortable with. And that's complicated because you have many data controllers. Every GP practices a data controller. You have a whole bunch of data processors. You have a whole bunch of people who hold contracts with your shared care record, et cetera. But we've managed, by using the governance I described before, to get everything aligned, to get agreement to have sharing right across the city region. So we've got agreement that the shared care record can be viewed anywhere in Greater Manchester for any patient in Greater Manchester, which is a massive step forward and wasn't in place before. And we've also got agreement that we can use that data for secondary purposes, including research. But to do so, we need to have the right kind of deep data protection impact assessment things and the right kind of scrutiny group oversight, et cetera. So that's been a big piece of work which we've now got over the line, which we're really excited about. The second bit is enhancing the GM care record. So what we have is a series, 10 different contracts with the GraphNet for the shared care record. And what we have been doing is optimizing the data flows into the care record and optimizing the way in which that care record will be used for direct care. So the sun is shining today, but with the sun shining and a fair wind behind, we will have 100% of all GP records flowing into GraphNet Care Centric by Monday. We've turned off a whole bunch of the filters which sit in the acutes to enable that data sharing to be happening GM-wide. And we're supporting direct care use by putting a reason to view screen in, which everybody's comfortable with, so that can be viewed at the point of care right across the care pathway. And we're accelerating a whole bunch of data feeds into that platform from pathology, et cetera. And actually what I think we've done is we've brought a 10-month program of work and we've got it complete within 3 weeks or so. And that's something that we've done as a direct response for the COVID-19. And, you know, I wasn't really involved in the nitty-gritty of that, but absolutely hats off to the people who have been, both on the kind of public sector side, but also in terms of the industry side. And that's been a real great partnership, I think, with GraphNet as our industry partner in that. So those things I think are really important. And what we've got is that going widespread next week with a whole bunch of comms and engagement support to make that happen. So I think there's real value in that. So those are the first two programs of work. What we've then done is we've been focusing on digital primary care, and I know there's some presentation on digital primary care, and the primary care has been turned upside down by the COVID-19 crisis, and there's been a whole bunch of central initiatives about driving that so that you get to digital first services. And there's different languages in this, which is not necessarily helpful, because I think it's quite confusing, but that's about having digital engagement with services. And I think a lot of people have interpreted that to telephone triage in terms of the front door, and in an ideal world it would be much more than that. It's then about providing the right kind of services through multi-channel approaches for the various things that primary care practices do for citizens. And some of those things, but not all of those things by any stretch of the imagination, are consultations, which can be done either by the phone, by video consultation, or by face-to-face. So again, that whole aspect of digital access, triage and consultation in place is something that we've been working with localities, with the NHS regional team, with NHSX and NHSE centrally, and with providers to try and accelerate that digital primary care. So that's the first thing. The second thing is care homes have been the poor relation in this, and I think we've seen that all over the media, particularly around PPE. But we've been doing a lot of work again with industry, and we're accelerating a new app into care homes, which actually does what we believe care homes require actually is technology, which is connected, with the right applications to connect care homes to the primary care services which support them, with the right applications on them for them able to manage their business better for their patients internally, and also potentially to provide connectivity before the residents, I should say, not the patients, but the residents and the loved ones in the COVID-19 era. But also to collect some of the data and do some of the reporting around PPE and stuff. So we've been working very carefully to try and accelerate digital offer to them. We've put in place one particular application on the right kind of hardware across 14 care homes in one particular part of Greater Manchester, which is very well received, and we're looking to accelerate that out. But again, that requires provider of technology infrastructure, connectivity, applications, integration, training, etc. A whole bunch of stuff around digital mental health, and I know there's more stuff coming up later on in this presentation as well. And the final thing that we've been providing is this support for the care pathway, the urgent emergency care pathway, in terms of supporting more effective and efficient flows across the system as we work. So that's a quick run through of the things that we've been focusing on. I think what's important in all of those particular projects is that they are direct responses to COVID, but actually they all have a legacy in a post-COVID world. We will end up having to do some of those things slightly differently, I think. We are responding to the COPI notice for our data sharing approaches, but I'm optimistic that we will still continue to share data in a relevant way post-COVID. And I think similar applies to secondary care. What I would say, I think for the purposes of this particular audience, is that when we've been thinking about secondary care usage of that data, we see 5 buckets for that. The first is around what I call business intelligence, and this is about cohort identification for support, service planning, delivery, enable us to track the epidemic, response to these sort of civic interventions. So that's the first bucket. The second bucket, I think, will become increasingly important, which is cohort identification for testing, which I think is going to be becoming a bigger issue as we move, including providing ongoing safe care for vulnerable people, as well as actually working out how we sort of release lockdown in a systematic kind of way. The third bucket is about research, particularly about the epidemiology of the disease and how it affects and who it affects and how it's progressing. The fourth is about cohort identification enrolling in clinical trials, including the ability to track long-term outcomes through routinely collected data. And the fifth bucket I call other research activities, including public and patient-generated health data, which I know is one of Niels's special areas. So those are the kind of 5 buckets of secondary use, which may be interesting for people on the call.
Right. Thanks very much, Ben. That was extremely useful, and it's great to see that so much is happening. Certain things are certainly very impressive, like the fast tracking of the integrated digital care records. There's been lively discussion through the chat. I'm conscious of time, so I'm going just to pick out a couple of questions. Maybe to start off with, and this is a question actually from myself, so that integrated digital care record, it was possible to do a lot of work that would normally would have taken about 10 months time or so, now in just a few weeks. So what, in your experience, Ben, has been crucial that we were now able to do this so quickly? What changed? So
it's a complicated landscape. Governance in a city region which is connected, like Greater Manchester, is complicated. I think having a mixture of command and control structures, so you have one clear hospital cell which is meeting regularly, one clear out-hospital cell, connectivity between those two things, and things like the COPI notice, which came out centrally, making a requirement for data sharing. Backed up by the kind of energy that we've brought into this in terms of having this data coordination, digital coordination group working across those things. You put all those things together, and I guess that's the sponge if you like. And then what you've got in terms of the kind of the jam and the cream in the middle and the icing on the top is I think we've got some extraordinarily capable people who've been driving this stuff incredibly hard with a mixture of kind of deep intellect, a huge kind of technology experience, and actually kind of great behaviors in terms of collaborating across the system. I think that's the jam and the cream and the icing sugar. But you put all those things together, you can get some kind of quite remarkable things done.
Yeah. Okay, another question that was already came through after your first talk is that, you know, we're making a lot of changes now to care services. So for instance, most outpatient consultations are happening virtually now. And a lot of people, so I've spoken to a lot of clinicians who are saying, this is fantastic, I'm never going to go back. So what are your thoughts on that? Do you think that indeed we can make that sustainable? Is there anything we need to do to make it sustainable, or would that not be a good idea?
So this, you know, I know a lot of the things I say just sound banal because they're simple, but this is about effective and efficient healthcare services, isn't it? And, you know, going back for many, many years when I was involved in doing direct clinical care, I kind of felt that some of the things that we were doing weren't effective and efficient. But quite frankly, you had to do those things because the business models drove you to do those kind of things. So what's happening off the back of this crisis is becoming absolutely clear for infection control purposes that you can't bring everybody and have everybody sitting in your outpatient room, which means you then need to do things remotely. And at the moment, we haven't actually cracked the issue about what is the business model which actually supports that kind of approach. So when I was speaking before about understand your population, define their needs, transform your operating model and transform your business model, what's inevitably going to happen off the back of this is the business models are going to have to catch up to provide the right kind of remuneration for providing those kind of remote services in a different kind of way. So I'm absolutely optimistic that actually that business model transformation will have to happen very rapidly now. So I don't think these things will ever go back and everybody will be the richer for it, in my view.
Well, that's good news, I think. So final question before we move on. Someone said it's probably fair, and so it makes a lot of sense to distinguish these different kinds of different waves as you did. I think it's probably fair to say in the fourth wave, we should also look at the economic consequences of what's happening currently and how that will affect the NHS and, well, the whole economy and society in the medium to long term. So what are your thoughts on that? Can we prepare for that, and how should we do that?
So it's interesting that there's some things that I know about, and I'm prepared to speak with some authority with the things I know about. There's quite a lot I don't really know about, and I guess you're breaching into that kind of area. I think what we need to be understanding is that the nature of this kind of response to this particular crisis is changing things, and the population need would change as a consequence. And I think those of us who are involved in giving care or innovating to support care need to be cognizant of that and rapidly changing our focus to be able to provide the right kind of support in that right kind of landscape, which is, I think, is something that we need to be doing, which is why I think thinking about those four waves is quite useful. Can I just pick up one thing, Niels, which I'm just going to say here to be a little bit controversial, and it's hard presenting on this thing and trying to listen to your questions and read the chat. But I do want to just talk about a comment which has come through at 10:41 about data ownership and stuff. I think what's happening off the back of this data sharing approach is a real kind of clear understanding that in response to COVID-19, we need to be sharing data in a different way, which I think is stressing some of the original arrangements in terms of how we do things. You've heard me talk about this before, Niels, but I think this is really important. When we talk about data ownership, I think we need to be very specific about understanding what we mean by that. So from the kind of legislative framework, there is no such thing as data ownership. It kind of doesn't work like that. What you have is a series of rights under the data, which include database rights. So have you invested significantly in collecting, in putting together that database? It's about copyright. And copyright is actually the same as writing a book, and you have that under the data as well. It's about confidence rights, and actually that's, are you using the data of individuals in a way which actually is compliant with the law? And it's about contract rights, and that's actually what have you agreed as a contract to do with that kind of data. So I think as we have these kind of conversations in a world where we have more data sharing, I think we are going to need to have more precision in the way we think about data ownership, understanding that actually that is the framework on which we consider those kind of things. What we will then have on top of that, as we move to a landscape of greater empowerment, is more patient-held data, where I can think legitimately in that you can have a contract between people who put the database rights together and those people who are contributing that data in there. But I think we do need to move to a more mature landscape of the conversations that we have about some of those issues.
Thanks. Yes, no, I agree completely. And whilst you were talking, I was thinking this might be a topic for perhaps a longer meeting or a next ecosystem meeting, because as you say, I think our thinking about this is changing quickly during this corona crisis. Obviously, there is a whole regulatory framework, legal framework in place that we still need to adhere to. But the thinking about it is changing. So it might be something that we can pick up at the next meeting. So thanks very much, Ben. That was extremely useful and much appreciated. I guess we will be able to share your slides after the meeting. Is that correct?
Yeah, that's fine. Yep.
Okay, great. So with that, I'd like to move on to our next speakers, who are Marcus and Gwyneth from Spectra Analytics, and who are going to talk about one of the things that you spoke about, Ben, briefly, digital triage for primary care and AI. So Marcus, the floor is yours.
Great, thanks, Niels. Can you see my screen? Is that coming up?
Yes, we can.
Great. Okay, great. Thank you very much for inviting us here to talk to you this morning. My name's Marcus Ong, and I'm the CEO of Spectra Analytics, and I'm here with my colleague Gwyneth Durreri, who's the product manager for Patches.
Hello.
This is my first virtual conference, so hopefully it's okay. But if not, we've got a chat function for any constructive heckling. So I'm going to start off by talking about some of the problem that we're trying to solve, and then some of the work that we've been doing around that. And then I'll be talking more about some of the challenges that we face while doing this work and how that's potentially been impacted by COVID-19 as well. So as many of you know, there's a big, even prior to COVID-19, there was a big challenge around primary care, people living longer with more complex comorbidities, more requirements for GP appointments, putting a lot of pressure on GPs. At the same time, we're getting a hiring and retention crisis, so less appointments available. We've had longer appointments, longer waiting times, less funding for primary care. So it's putting a lot of pressure on the system at the moment. And that's making it difficult for GPs to actually see patients when it's clinically required. So one of the potential problems around this is that it's estimated that 27% of GP appointments are actually potentially avoidable. So that's people self-caring, going to the pharmacist, seeing the nurse. And there's been quite a lot of work around trying to direct people to those different, more appropriate forms of care. But there's still quite a lot of work to go there, and it's not generally in use by everyone. So if we can implement more effective triage procedures, so directing them to the correct healthcare professional, we can potentially help manage that workload. So there has been some things such as telephone triage, which has been very effective. That's seen face-to-face consultations in some cases drop by like 50%. But research shown that actually that's increased GP workload by 8% because it's just changed the way in which people actually try to use their healthcare services. So there's been, I think it was a threefold increase in the number of people calling up their GPs. So there's different challenges with different solutions. And in a lot of cases, some of the GP practices, a lot of the staff having to perform some of these functions, which is actually putting a lot of human resource impact on it. And as we know, this situation has been made even more difficult by COVID-19. They're getting an increase of people contacting them with COVID-19 related symptoms. There's been anecdotal evidence that there's an increase in mental health issues resulting from isolation. And there's also a big concern about the reduction in patients actually contacting their GPs with other health related issues because of COVID-19. And this could be storing up lots of problems in the longer term around such as things as cancer care. The other challenges around it is we now need to provide remote consultations because there's very few face-to-face consultations available now, if any. Then some of the problems that we've seen with the practices we're working with is some of the staff has been off from the different GP practices. So staff from one practice are then having to try and help and support other practices, which can be very difficult with the way some of the systems are set up. So, as I said, one of the solutions for this is what NHS England are now calling total digital triage, and that the recommendation is where it's possible, GP practices should be implementing this process. So this is basically people are either calling up the GP practice or entering the symptoms online, then being triaged by a member of staff and past the appropriate care professional, who then can go back to the patient online with messages or video consultations or telephone consultations, or where possible with face-to-face consultations. And this all comes in a broader thing around online consultation, which we'll go into talk about in a bit later. But one of the general problems I would say with this online consultation term is it's very broad. Lots of people are doing lots of little different bits, but from my perspective, all of those bits are really important. But actually, this being able to triage and work out who are the important patients they really need to see on a clinical basis is one of the most crucial aspects, which needs to be included. So what are we doing? So we've developed a tool called Patches, which is delivering total digital triage. We've had to change some of the processes a bit for COVID-19. So initially we were doing more hands-on onboarding. Now we're doing that fully remotely to practices so we can get them set up quickly. We've obviously seen a big increase in demand as a result of everything that's going on. We've also been using more online patient registration. Unlike when I did the single sign-on, I had to go into the GP practice and get all the details that then I could go back and register with all these special codes, things which made it rather difficult. But actually the way we're doing it at the moment allows the patients to register themselves. And obviously there's been a much larger take up in actually patients signing up as opposed to calling the practices. So in our solution, patients can access the Patches system directly through the GP practice website or via a smartphone app, and they simply type 4 free text questions. So it's very easy for them to actually submit their request. This is opposed to some of the other tools that are out there that have very long questionnaires. They're very time consuming, and they don't necessarily give some of the context that the patient wants to give around their symptoms. Then we provide the full triage and workflow management. So all the information is sent to the GP that they can then analyze all the patient's symptoms and relevant other information, and it allows them a workflow to assign the request to an appropriate member of staff and go back to the patient. They can do two-way messaging, And obviously, as a result of everything that's going on, video consultations have been very important. So we've been asked by the practices to expedite that. So now that's in use by quite a few of the practices, and that seems to be working well. The federated working was also a very important aspect. That was probably a bit longer down our roadmap, but that's something, again, we've had to accelerate because in this new paradigm where the practices need to be collaborating more to provide the services. And as I say, it's also an NHS approved online consultation system. One of the interesting things around the stuff that we're doing is we're also developing artificial intelligence to actually further automate the triage process. So at the moment it's being done manually by GPs, but we're collaborating with Niels's team to develop an AI that automatically analyzes all the patient's symptoms and the context of their symptoms and combine it with other things such as pre-existing medical data to actually tailor triage recommendations. So we're not doing diagnosis, we're just trying to work out how urgent is it and who is the most relevant care professional to look at this patient. And I think the important thing around this is the AI is actually being trained by all the GPs are actually using the system. So every time they're actually manually triaging a patient at the moment, they're what's called supervised learning, is they're giving labels to teach the AI how to make those decisions for them. So potentially it can learn from thousands of GPs at the same time. So this is quite different from some of the other approaches. So other people would perhaps use more like an expert system approach where you go through a series of different questions, might be using methods such as Bayesian hierarchical networks and things like this, which is a really good way if you've got expert knowledge and you want to put it into a model. The problem is it's perhaps not so flexible in terms of it's very focused around the knowledge that the people who are actually developing the models have around developing it. So whereas what we're trying to do is learn directly from the correlations within the data. But obviously the challenge around here, which has prevented people doing it in the past, is that people don't have access to all of that data, and it's very time consuming and expensive to actually collect it. But we've been funded by Innovate UK to actually go through this process of developing this AI. So this is something that will be coming along sometime next year probably, but it's already in development. We did a feasibility study last year and we found we were getting a similar kind of accuracy level to that of the average GP. So it looks very encouraging at the moment. Practices will be able to decide, you know, if they're not comfortable with using an AI, they can continue to do it manually, or they can do it having it suggested and then approving it. So we have a variety of ways of making that work depending upon the practice's requirements. So the other really important aspect with a lot of these online consultation systems is, do we actually really know it's actually delivering a benefit to GP practices? There's a lot of solutions out there, and as we said with telephone triage, that has been great at reducing face-to-face consultations, but the indirect consequence is actually increase in GP workload. So again, we're collaborating with Manchester University, and we have a team of research associates who are actually conducting qualitative research with patients and GPs, and we're also doing quantitative analysis of the data that we're collecting to work out what the benefits are to the practices. And I think we're obviously going to publish these results as well. So we think this is a really important aspect for us. Everyone at Spectra, well, most people at Spectra are scientists by training. So we want to have that rigor and that confidence that we're actually delivering a benefit. So actually publishing independent research and having that peer reviewed is a very important aspect for us. But obviously it's a process that takes some time. It's also been really useful for actually the development of the software, because we've been getting feedback from patients and staff as we've been developing it, and we've been able to implement those into the workflows to actually improve their experiences. So scaling patches. We've been trialing patches, and we originally developed it in Salford. So we did the feasibility study early last year, and we started trialing the actual software itself at the end of last year, beginning of this year. And we've taken a rather different approach to other people. We've partnered with one of the largest software companies in healthcare, which is Advanced, who are the suppliers of DocMan, who are in many GP practices. So they're actually delivering and supporting patches for us now. So obviously, we're fantastic at doing. I think we're good at doing the development of technology and AI and all that kind of side of it. But what we don't have a lot of experience around is actually scaling solutions and supporting them in those ways. So actually partnering with a large company who is national, has all the customers already, has been a great way for us to actually get it out to practices, give the practices the confidence that it's backed by a company that they know, and they have the staff to actually support it while it's out there. If there are any issues or the practices need help, Advanced are there. So people might say, perhaps you're going too quickly. You know, you're getting it out there while you're still, you know, you haven't been doing it for like several years or so. But we have changed our process as a result of COVID-19. And we've done that on the basis of feedback from GP practices who've been using the system so far. They found it really helpful in terms of delivering their care to patients. It's automatically sort of digital by default, and it provides that remote access that they actually need to provide consultations and to collaborate with other practices. So we're actually doing it as a phased rollout. So we believe we're doing it in a very careful way. And if obviously there are any issues, then we would stop delivering it out further, but we're making those adjustments as we go. So far, we've not had any issues really, and it's a very scalable solution. Yeah, at the moment it's going very well. Patches, because Patches is funded by Innovate UK, it's actually freely available to all GP practices until the 31st of March 2021. Just to caveat that, the video consultation is an additional cost because we provide that through a third-party integration. And we've managed to get Advanced to also support it for free during that period, which is great for people who want this kind of solution. And it gives them an opportunity to try it in a low-risk way, and it helps support them through COVID-19 as well. So what are the challenges? So the challenges are numerous. So one of them is making the benefits clear to GP practices. Some of the GP practices have used solutions before and it's not really helped them. It's actually increased their workload. Some of the solutions don't do everything that they need them to do. They're very busy, so actually getting the time with them and for them to learn and implement a new system is difficult. And this also comes into the aspect of there are so many products out there. So there are some products that mainly do online booking of appointments and accessing the electronic health record, but they don't do any triage as part of the process. There's others that do just video consultation. There's some that do bits of both. And that makes it very difficult for practices to actually differentiate. And then sometimes they're getting different messages from the CCGs about what products that they've been using and should be using. So it's a very difficult situation. We've been lucky with our work in Salford that we've had the team of with Gwyneth on the ground, and also some of the research associates with Manchester. They've been talking to the GP practices and asking them about their needs and seeing what is the things that they really need to, challenges they need to overcome. Sorry, I've run over time, I think, haven't I? But I'm very close.
Yeah, Marcus, sorry for jumping in, but we are a little bit short of time.
Sure.
So would you mind that we progress to Q&A?
Yeah, absolutely.
Okay, great. Thanks. Thanks for giving this overview. I think it's a really exciting piece of work. As you mentioned, I'm involved in it as well, but even if I weren't, I would think it's really exciting, especially the AI bit. There was a question through the chat about that, which I'd like to raise to you, which is that if we are currently gathering data through patches, and that data is being used to train the AI model, perhaps there could be a bias, because currently we're in a very specific situation due to COVID-19. So would that AI model then still be applicable in the normal situation? How do we deal with that challenge?
Absolutely, that's a very good question. And there's certainly going to be a disproportionate number of, as we said at the beginning, people contacting with COVID-19 related symptoms. And also we'll see a reduction in the number of people with other symptoms requesting appointments, because they're actually concerned about, they don't think they'll be able to speak to their GP very easily. Or they don't think they can have treatment very easily without going somewhere and potentially contracting COVID-19. So what we would do in those situations, one is we do something called stratification. So we will split the data up and actually try to focus on people with different types of symptoms. And then we would also be collecting data over a longer period of time when this situation has also settled down. Originally, the Innovate UK funding was actually around developing in between 10 to 20 GP practices in within Salford. And actually for our feasibility study, we only actually collected 10,000 patient requests. And actually that came out to a similar accuracy levels of GPs, which anecdotally, or well, there's some research, but it's around 80% accuracy. And as part of this research, we're also trying to nail down actually what the GP accuracy is to be able to compare it to our algorithm. But so now with this new approach of actually, because we're delivering it at a much larger scale, we're going to be collecting so much more data, actually we'll be in a much better position as well to collect all of these symptoms from other issues as well. So hopefully that will improve the efficacy of the algorithm. But we wouldn't be releasing the algorithm unless we're confident that it's actually working as expected. And that's part of working with Manchester as well. You know, they're evaluating it and it will go out to peer-reviewed publication.
Right. Okay, thanks very much, Marcus. If people would have any questions about patches, would you be happy to be approached by them? Is that okay?
Yes, absolutely, of course.
And we can share your slides as well?
Yes, sure.
Okay, great. Thanks again. And I suggest we move on directly to the two final short presentations, the Industry Partner Showcase. So the first of that is provided by Scott from 42nd Street, and it's about adolescent mental health charity. So Scott, the floor is yours.
Hello. Right. Let's see if we can share this. I shall be incredibly quick and just sort of go through everything really quickly here. So for those who don't know, 42nd Street, we're a mental health charity. We work with people 11 to 25 across GM. And by sheer coincidence, for the last year or so, we've actually been working on a pilot for our online project. So we're in a unique position to actually just roll it out really quickly in light of COVID-19, really. So basically our face-to-face service has effectively shut down, obviously, as of like a sort of month or so ago. And we've migrated everything to 3 different options for young people to access support. We've got like telephone-based support, video-based support and also text-based support during this platform that we've been developing. It's from a gang called Iguana down in London, and it's used by about half a dozen partners or so nationwide. So what I'll do really quickly is just sort of run through how we've managed to set it up, what it looks like, and how we're kind of finding the experience at the moment. As you see, it's being co-designed with young people. I know, Ben, you were talking about different aspects of innovating and empowering people. So we're trying to give the people who are using the service as much control over it as we can by getting them to add content to it, to make kind of changes to it as we can. And you also get a choice when you come to it. As I said, you've got like the telephone, the video, but also you can talk to us in real time, like a kind of instant message. But you can also talk to us asynchronously and sort of messages throughout the week, use it as a journaling thing, however really works for you. And we can be really flexible in terms of how we're offering support. What we're finding is a lot of people initially, when it comes to remote support, jump to the idea of video-based support. And then when it comes right to the moment of accessing support, realize that there's all manner of confidentiality issues involved with that, especially younger people who don't have the space they ordinarily would do to talk about the issues they talk to us about. So we're actually switching to a text-based kind of service because then they can express themselves a little easier. Service that we use the same outcome measures that we do in our face-to-face stuff. So we use like core, YP core, ORS, SRS. So we're funding into the exact same data set. And our hope is that we can make a really robust evidence base for kind of how we're working, really. So what the service looks like, it's an online support, 40secondstreet.org.uk is the main bit that I'm going to take you guys through because it's the kind of the innovative side of things. It's a self-referral system. So it's not like gatekeeped via like any kind of referral thing like CAMS or GPs or anything like that. You can come straight to us. You get a short little bit, so we try to keep it as simple as we possibly can. And people can come in, tell us anything that they want. And again, it can vary from a huge amount of information they give us to a small amount. And there is a quick form. So we had like a decision around keeping the service entirely anonymous. Like obviously Kooth is a massive, amazing provider that is more or less anonymous. But because the support that we're offering is kind of longer term and it's based sort of quite on a relational therapeutic setting, and we use all the outcome measures, we ask for some details from the young person, and that really helps us with safeguarding. And we've got all these opportunities to kind of get in touch with young people if they do kind of share with us anything that's concerning. You can text us, you can obviously share videos, music, files, anything like that. And obviously young people can have access to that throughout their support. And they get the outcome measures sent to them every week so that we can share their journey with them, and we can have like the outcome measures and graphs and all that kind of stuff so they can kind of see the progress they're making. And the other bit that our platform does, oh, there's another graph there, is offer webinar things. So we've got built into our platform, and it's supported by Click Meeting, is this kind of webinar function. So we've got 9, soon to be 10 groups with young people running throughout the week that are identity-based. We've got like an LGBT group, we've got young carers, women's groups, therapeutic communities, and they all sit on this platform. And the thing we like about it is that it's really flexible. So you can switch between it being video, much like we're doing at the moment, to it being text-based. And you've got these interactive whiteboard spaces. You can share video content and all sorts of stuff like that. So that's working really well with young people. Like I said, we've been experimenting with it on a really small scale in Salford through the Innovation Fund. And now it's kind of rolled out with funding from Health and Wellbeing Fund, from a national pot, and some GM funding. We've had, the moment you can see, we've had 82 people come to it since we've rolled it out in October of last year. We've had another 67 that we've transferred to it since sort of COVID-19. We are seeing a huge amount of distress on it. So 97% of people coming are showing clinically significant level of needs, and 91% of them are showing moderate to severe. So we're kind of working with quite complex stuff at the moment. But at the moment, 80% or so are showing positive change, and 75% are clinically reliable change on there. And you can see from the stats in the bottom right, that part of the agenda behind this was to try and reach communities who wouldn't ordinarily access support. So LGBT, BAME communities, young carer, and that's the kind of aspect that we're going with it. And hopefully, I suppose I use the word normal in inverted commas, when we return to that, we're going to keep this offer going, and we're going to have the telephone support and the video support and have that whole range of opportunities for young people. And that is a really, really whistle-stop tour.
Okay, sorry for jumping in, but we're eating into Will's 5 minutes here, I think. So thanks for that. And we're going to move on directly to Will's presentation, Will from Keystream Group. Will, the floor is yours.
Right, hello everyone. I'm conscious of the time, so I'll aim to keep it as brief as possible. Now, can everyone see my screen?
Yes, we can.
Perfect. Right, so we're Keystream Group. So we're a rather small company. We are headed up in London, recently launched kind of within the Northwest last year with an event around digital within healthcare and kind of transformation. We've got two arms to the business. We've got Keystream Consulting, which helps to deliver digital projects into the NHS. So that can be from anything from kind of an estate refresh to Windows 10 to Office 365 to a new program. And we work a lot with kind of primary care organizations, as they may not have the, I suppose, the talent or the expertise to deliver the strategy or to develop the strategy as well as to deliver the project. So it's an end-to-end kind of project management arm, I suppose you could say. And then we've got Keystream Analytics, which I think is a bit more interesting and probably a bit more relevant to the conversation today, which kind of aims to kind of address the key pitfalls within business development at the moment. A lot of that being, well, before COVID-19, was kind of the interpretation of data. So you may be given data, but it might not be interpretable. So making data insightful. If you receive information, being able to make kind of decisions on that without having to ask someone else to dig deep. So a lot to do with kind of self-reporting. I suppose our main aim is kind of connected with the ecosystem is kind of work collaboratively. We found a lot of times when we first started Keystream Analytics and Consulting is a lot of times when you go in and develop a new system or process, you'll leave, what you've done will change dramatically. So when you leave, the system won't be as kind of polished, I suppose, as when you were there. So what we aim to do is kind of engage the current teams within the organization so they can carry on and they know exactly what we've developed and what we've kind of integrated into their systems, so they know how to kind of accurately maintain them. Kind of the BI side of it is, again, overlapping data, especially with the Leica program in Manchester, is creating systems that are integratable and can work with new systems that come into place. And I think the the main thing is probably self-reporting. So you know, any line management can have a look and see how their department's doing and kind of make insights in that sense. That was incredibly brief. I mean, if anyone does have any questions or would like to go over it a little bit more detail, I'm happy to have a conversation afterwards, but I'm conscious of the time and I know there's a Q&A after me, so probably hold it there. And then if anyone wanted to catch up later, we can just drop me an email or a message.
Thank you very much, Will, and thanks for keeping it so short. And sorry that we ran over a little bit in the previous part of the program. What I would suggest is that we stop the formal part of the program of the meeting here, but I'd like to ask you, Will and Scott, and perhaps also Marcus and Gwyneth, if they have the time to stay in the meeting for a little while. I'm conscious that people have raised some questions through the chat, so maybe you could respond to that. And this will also give people who still want to have a conversation to do that through the chat with you. So with that, I would like to firstly thank all our speakers today. It's been extremely useful, and I think a very good way to still continue the ecosystem meeting in this challenging time. And obviously, I'd also like to thank all our attendees today. Thank you for joining, and we hope to have another ecosystem meeting in June. So obviously we will be in touch with you. If you have any feedback for us, any thoughts about how we should organize these meetings, what we should change in terms of form or content, positive or negative, please let us know. We're very happy to hear your feedback. So thanks everyone and have a good day.